Welcome everyone. Good afternoon. We're getting everyone joining our session. Thank you so much for logging on with us today. My name is Krista Sineski. I'm the Vice President of Marketing with EloQuest Healthcare. We're so pleased to have you here today for one of our Wednesday workshop sessions. This is a format in which we hope to help you improve outcomes in your facilities by sharing information and resources from some clinical experts. Today is the second in a three-part series, which is entitled Growing a Vascular Access Specialty Team, One Step at a Time. We'll be hearing from presenter Lee Steer, the manager of the IV team at Hartford Hospital. Before I turn it over to Lee, there are just a couple of quick housekeeping notes that I want to share with you. First of all, as you probably noticed, as you enter the webinar, you do have your audio automatically muted, and that's to avoid background noise. However, we do like to encourage interaction, and if you have any questions for our speaker, you can type them into the question box in your control panel. They can be submitted at any time throughout the presentation. We will hold those questions to the end of our session, and Lee will address as many as we can in our brief time allotted. Also, we do have a couple of audience poll questions that Lee has prepared, so please do interact with these when they appear on your screen, and we'll get to see the results of the audience perspective while we're here in session today. And finally, there's also a wonderful handout you can find in the handout section of your control panel about a patency assessment algorithm that Lee will be sharing in his presentation as well. So make sure you get a copy of that before you log off today as well. And with those out of the way, I will introduce today's presenter. Lee Steer has been leading and growing the IV team at Hartford Hospital for nearly 20 years. At his facility, all PIVs are inserted on inpatient units by the VAST team using a bundled approach. Lee has spoken at multiple local and national vascular access conferences on CLABSI prevention, CVAD occlusion management, and PIV insertions using a vascular access specialist and bundled approach. Lee is a member of the hospital's HAI committee, and he is the chair of the Hartford Healthcare Patient Care Clinical Value Team. He's the author of multiple peer-reviewed publications and is the principal investigator of an ongoing randomized controlled trial. So please join me in welcoming back today's Wednesday workshop presenter, Lee Steer.
Thank you, everybody. Good afternoon and good morning to those of you, depending on which time zones you are in. Thanks for joining me again on step 2, planning implementation, growing a vascular access specialties team, one step at a time. Today's learning objectives, step 2, planning implementation. We're going to talk about determining team size and the related budget that you need for that. A lot of it's going to be related to how do you really create the team size by and the budget by really showing initiatives that minimize waste. So we're going to talk about finding those solutions to minimize waste, organizing the team. I'm going to show you a picture of a visual management and a lot of discussion around that, how we organize the team for the day, and then a little bit more on capturing data, surveys, point prevalence, slicer, dicer. So just again, Hartford Hospital, Hartford, Connecticut. It was built in 1854, level 1 trauma center. It's just growing. We keep on adding new ICUs, new PACUs. We have lots of transitions each year, over 40,000 with, I think on budget this year to be with over 100,000 ED visits. I always like to point out we are a lean facility, so we do focus on looking at areas of opportunity to minimize waste. And I think that is an important thing to note because that has allowed me and my team to grow exponentially over the last good 7 to 8 years. Our core values: caring excellence, integrity, and safety, and we just added equity to that to be our 5th one. Those are the values that we live by, and everything that we do at Hartford Hospital, me and my team, we always try to focus on those core values, what our upper administration is doing as well. The Journal of New Infusion Nursing, their standards that was published in the January-February edition of 2021, talks a lot about IV teams, and I'm hoping that in the next bit of standards, we're going to see a little bit more of that. But they really talk a lot about, the success of having a vascular access team on first sticks success, how it really we should be looking at creating a vascular access team or organizing a team of clinicians that can deliver infusion therapy in an acute care settings. But what I really want to focus on this is a little bit of the comments in the red. Establish the infusion team, that is a revenue cost center in acute care facilities, allowing the team to track and analyze services provided. That is extremely important to do, and something that we've been very successful at Hartford Hospital that has allowed us to grow our team to the current size that it is. We're going to go into a poll question. Does the VAST perform PIV insertions at your facility?
All right, it looks like we have the clear majority does have a vascular access specialty team, yeah, some don't have a VAST at all.
All right, cool. We like that. So this is where we stay past and present state and what I look to be hopefully the future. In 2015, our past state, we had 7 RNs and 2 LPNs equaling 7.35 FTEs, about 294 hours to our budget. Because of the things that we've been doing at Hartford, and that's in terms of, projects, ideas, generating ideas, putting them into action, that has allowed us to grow our present state of 30 nurses. 3 of those have been to clinical nurse leaders to help me manage the day-to-day operations of the department. And look at how big we are, 25.65 FTEs. We still do have 1 open position, 40-hour assistant nurse manager educator position. We're sort of questioning that one right now, but just because with the 3 clinical nurse leaders that I have, we really seem to be doing pretty well in what we're doing and managing the day-to-day operations. But right now, still open, so please apply if you would like. A lot of that really comes down to our productivity index, improving our efficiencies and how we work. This was a slide I showed in our last presentation because I think it is super important. And what really feeds this productivity index is what allows me to be able to keep increasing my budget. So productivity index, we're always hoping to be at 1%. I think the hospital raised the threshold from 90% to 98%. That'll keep us in the green. But what feeds this is most important is really knowing what your billable CPT codes are for infusion therapy. There's not that many out there, so that can be a little bit problemsome, because then really what you have to do is start looking at the things that you do that you cannot bill for, but that really takes a lot of time. So for example, if you look at the last line here, completion of certain orders. So every time we click the button to complete an order in our Epic system, for Dopphoff tube placements, for central venous catheter removals, for dressing changes, ultrasound guided IV insertions, and there's one more that I don't have on there, but that is port acting. So those are all things that we currently cannot bill for, even though you can bill for ultrasound guided IV insertions, but you actually have to download an image into Epic, and we're working on that right now. So that's going to actually add a very nice piece of revenue, because my staff uses all ultrasound for their insertions. But this is very important for us. And again, if when every time I have a position that I either want to fill brand new above budget, or a position that I want to get refilled because somebody left the department, it's very important that we're looking green and looking good. And a lot of that comes down to making sure that I also cost shift hours appropriately, especially if people are in education. But one of the important things also about this is that I do keep our overtime. It records it, and we are less than 1%. So that helps a lot. When your productivity index is down, you can always say, well, at least we're keeping our overtime down as well. This is our visual management board. It's where we start our day every single morning, 7 a.m., and we end our day at 7 p.m. There as well. So basically what we look at is reviewing our daily playbook. So who do we have on for staff for that day, and what are the things that we need to get done? Where do we stand at 7 a.m. and how are we going to manage the day? We do a lot of recognition. We do important hospital or departmental announcements. And then we look at drivers. Our drivers are centered around central line rounding, It's around productivity, and it's around hand hygiene compliance, although that will probably change in the future because we seem to be mastered that one at 100% weekly. But most importantly, this is where we review new ideas. We also have learning moments. We have 52-week educational sessions, so every week we pick a new one. But again, what I really want to focus on is the new ideas that get generated here, because when an idea comes up, we look at, is it going to be an easy thing to, get done, and to implement, or what's the level of difficulty that it was. So this is where we've come up with the idea of eliminating waste in a lot of different areas, especially around PIV insertions. And when we look at waste in healthcare, waste isn't endemic, and it's a problem. This was Derek Foley, President CIHI. He looks at waste as health system leaders and all who work in healthcare need to really heed this call, and that is trying to find anywhere where we can reduce the waste that's out there. Especially if it's non-value added waste causing the U.S. healthcare system, millions and billions of dollars. And if you look at one, CLABSIs is a good example of that, 1.4 billion in 2018. So it's one of those areas where we could really reduce the costs and give it back to our to the patients. And here's another reason why. So I know this is a very busy slide, but our gross domestic product, which is the budget for the United States of America, in 1970, 6% of that went to healthcare. In 2021, it was 17.8%. I actually thought it was going to be higher because in 2019, it was a total of 20%, I believe. So it's actually gone down a little bit, but it still continues to remain the largest increase than any other country. And I liked a couple things. The one thing in red here continues to be healthcare spending, both per person as a share of GDP, continues to be a far higher in the United States than any other high country. So we really have to get a handle on this, and by finding ways to reduce and eliminate waste, that's how we can, support trying to bring the GDP and healthcare down. Here's a prime example. So in the United States, there are 350 million peripheral IVs manufactured annually. They say about 151 of those will be inserted successfully, but just in the manufacturing process and buying that many, I did a little cost analysis here, and I used $1.50 per catheter, and that's just for the catheter only. Just on that, we are spending over $525 million on $525 million on just in the creation of peripheral IV catheters. Now, with the average cost of peripheral IV insertion at $28 to $35, like it says in the literature, that means if we're successfully inserting 151 million, that we're spending $4.2 to $5 billion. Now, I think that's just huge money, and I think that we could really reduce that if we can, get to better at our first stick success rates using ultra infrared, but also by making sure that they last as long as they can without before early failure. So that means trying to get one in that lasts until that patient care is over from an infusion standpoint. When we look at eliminating the waste, especially in infusion therapy, Dr. Bob Helm did a study, and he looked at a range and randomized clinical trials, and he found that the average IV fails 46% of the time before their intended use is complete. Now, I truly believe that this is very low number. I think it's probably higher. Why? Because most peripheral IV complications are underreported, and I think everybody would agree to that. Because when a peripheral IV catheter fails, most caregivers and healthcare institutions just have traditionally accepted it as necessary additional work to be performed. So the IV gets a little infiltration, identifies it, notifies the nurse just comes in, takes it out, and puts in a new one. But really, if we look at it from the patient perspective, a failed catheter means pain, dissatisfaction, prolongation of care, and venous depletion. And then that is all compounded by the need to treat minor and major severe IV catheter complications. So, and I have a lot of those. I've actually patients who've had to have amputations due to peripheral IV catheter extravasations that were so bad that they couldn't save the arm. So scary stuff, but also an area where I know that all of us could really focus on in trying to reduce waste and show value to our organizations, which also would allow us to grow our teams. This is, again, looking at our work at Hartford Hospital, where we tried waste, variability, and defects. We really did focus on peripheral IVs. And if you look at these were the patients that we actually admitted into our study, the PIV 5 right study. And what do you see here? There's no consistency, different dressings, different tape techniques. Actually, the only consistent thing in any of these pictures is actually the placement, and that is either the hand, the wrist, or the antecubital fossa, which are all non-recommended areas for peripheral IV placement, and hence the reason why our failure rate at Hartford with these was 15%. I'm sorry, 85% failed before they made it to the end of treatment. Whereas if you look at our current state, and this is what we're currently in our standard work, PIV 5 rights, evidence-based best practice, we're putting them in the forearm, we're using the smaller catheters. There are a couple 20 gauges in here, which are fine. I know there's been some studies done between 22s and 20s, and some of the studies even suggested that 20s were a little bit better. We use an anti-reflux needleless connector on these, which does not require any type of flushing clamping sequence. We're using an antimicrobial dressing, border dressing, and we can actually see the site through the chlorhexidine that's impregnated into the clear portion dressing. So that is, sites are lasting longer. We actually had in the study an 89% of our catheters lasted from the beginning to the end of therapy, and we had a 29% reduction in complication rate. So, if you put the numbers to it, that would indicate that we are putting in less IVs at Hartford Hospital, which is, again, eliminating unnecessary waste. With that, we were able to take over all peripheral IV insertions on the medical surgical units. But one of the things we really had to do, which I hope all of you are also working on out there, is creating some standard work around peripheral IV and central venous catheter rounding. This is what it looks like, one of our standard work forms. It literally outlines every step somebody takes the minute they punch in to the minute they punch out. And what this allows us to do is allows us to proactively round before the nurse goes in and finds the IV or the central venous line dressing off. We go in, we basically start out by making sure we look at all the new admissions to the units with a length of stay of either 0 or 1, and that helps us to target those patients that we want to go see first, seeing what their site looks like that came out of the ED, and then we'll round on everybody else as the day permits. So very important thing for us to do, because one of the things I have found, as we create and put these interventions into play, is that we really need to create standard work for our teams. One of the ways standard work has helped with us as well, and continue to make sure that we sustain interventions that we put in place, is one of them was around our CVC patency algorithm with the evidence-based interventions. We created this after implementing the anti-reflux needleless connector, because what I did find is that still some of the staff were doing things a little bit differently. So we created this and targeted education around that. They know it, by the back of their hands, because what it does is it helps us keep our TPA consumption for central venous catheter patency way down, whereas we used to be 119 milligrams a month. Now we're down to 40, anywhere from 40 to 60 milligrams a month. A lot of those, again, are things where, could be controlled. We do have the better anti-reflux needleless connector. We have, specialists who are making sure to assess every single line before the TPA is ordered, versus prior, where the nurse would order TPA very early on, and that's just, again, another waste. 75 milligrams per milligram adds up over time. How do we control the proper use of TPA? One of the things that we had to do at the system, anytime you're a system and you go onto the same electronic medical record, it's very hard to put one thing in one place and not in another. So one of the things that we decided to do was create this order. So when a doctor goes in and orders alteplase for catheter clearance, this screen pops up, and the only thing that's checked is IV catheter checked by IV team. So in order to order the cath flow, they would have to check the alteplase button right below that, but they don't. They just, because they're always in a rush, so they send this, and that sends an order to my team and our work list. That means we go assess, and then we are the ones who end up ordering the TPA at the end of the day. The nurse gives it. We're thinking about taking maybe to a point where we start to administer it, because there's actually a billable CPT code available for this, which again would only increase our budget. We're currently budgeted to make about 26 million this year, so this would be a nice little addition for upcoming fiscal year 2024. This is called a slicer dicer. You can actually pull this up in Epic. So this was our TPA usage, 1 to 2 milligrams, January 21st to April of 2023. We do aliquot our TPA, meaning that the pharmacy with any leftover TPA freezes it in 1 milligram doses. It's 1 milligram is plenty for most IPAs. We do use 2 milligrams when we're doing ports or dialysis. But what this does, it just goes to show you again how we've been able to keep our numbers fairly low. Some months we were actually super low in terms of our TPA administration. So again, a nice little tool that is available to me in Epic called the Cognito Slicer Dicer. The other place that we're showing, again, a lot of waste elimination is in our outpatient antibiotic parenteral therapy unit. This was a program started way back in 2014, just treating patients for blood products and platelets, but we've turned it into much more. So, and one of the great things about this is all the projections that I show do not show anything about days saved transitioning inpatient to OPAT. Our average OPAT is 23.71 days, and that's 23.71 days out of the hospital setting. So you turn an inpatient that you weren't making money on into a revenue producing patient in an outpatient setting. We've also transitioned a lot of patients right from the ED to OPAT instead of having to have them get admitted. And we've also saved a lot of days in the inpatient beds caring for blood and blood product patients versus admitting them to our oncology unit for the day. And it usually would take them all day. So the patients are very happy about it, because they get in and get out. They have an IV team member that's always there doing their IV and their infusion. And it's a nice little revenue projections for fiscal year 2023 at 6 million plus. So nice again, area where we're contributing value to the organization. So we do have another poll question. Does someone in your facility routinely perform bedside audits of vascular access devices?
Okay, we got a good number of people who've replied. Oh, it's great results. 55%
like
said yes.
That is amazing. I'm really happy with those results. One of the things that, I always try to stress to anybody I present to, or, folk, if I'm in a conference talking, is the value of our, the value of our vendors. They want to help, and I have a great person I work with in my area, Annie, and anyone on the Eliquis team has just been wonderful. But they come in, they follow me, I give them a call. They're usually there in a week. I say, I want to go see every single central venous catheter in the hospital, so bring your rollerblades and let's get ready. I have long legs. They do a great job at keeping up. But yes, we go see every single patient, and we do what they call point prevalence studies, just to kind of see where do we stand. So one of the things that I'd like to even do often, we probably do it maybe twice a year right now, but I would absolutely love to get to either do it every 2 months or every 3 months. And I know Eliquis would support this. Is basically they come in and they have a little sheet that they follow. It's very non-biased, besides me doing it myself, but I want to be very serious about this because I need administration to know that the things that we're doing is adding value. So one of the things we try to look at is how well is Mastisol working to keep our dressings where they need to be intact, because we also know that after the third unplanned dressing change in the TIMSIT study, that you increase the risk of a patient getting CLABSI tenfold. So it's a very important thing to look at. So if this is just an example, it outlines what line we saw, whether the dressing was intact. And on this one, it was 70.2%. I think this was an earlier study. The last study that we did, I believe we had a 77% intact rate. But what I do enjoy about this one, in any one that we do, and especially the last one that we did, we found no partially detached or totally detached. And it's a good chance for me to get out there, talk with the staff, look at things. And so, again, most of what we find is just that the edges are lifted. So usually what that means is that the staff just didn't outline, whoever was doing that dressing change did not outline the area that the edges of the dressing were going to touch well enough. So usually that just helps reinforce the need for additional in-servicing and education. So important stuff though, again, the minute I got this, or the minute I get any report, I usually alert our HII committee that we're going to start doing, some rounds, and then, I'll have a report to discuss with them pretty quickly. So, and Eliquis is always so great about turning around the results very quickly to me. So that is pretty much it, but I do want to point to everybody that there is a downloadable free resource. It's an algorithm and on eliminating TPA and keeping our catheters patent. And I hope that all of you can join me on growing a vascular access team, specialty team, one step at a time. Step 3, ongoing evaluation, Wednesday, June 28th at 2 p.m. Eastern Daylight Savings Time.
Great, thank you so much, Lee. We really appreciate you taking us through so much information in such a short amount of time. This is the Q&A portion that we have for everyone. So if you do have any questions for Lee, feel free to type those into your question box now. Do you round on all PIVs and CVCs every day?
No, not every day. It would be impossible. We are an 867 bed facility. So what we do with our central venous catheters is we actually print up all the central lines in the hospital on Tuesday, Thursday, and Sunday. And that buys us a couple days in between to try to get as many as we possibly can. I mean, the staff know, it's part of one of our drivers. There are days that we get 100%. There's days that we'll get 75%, but our ultimate goal is to see 75% of all central venous catheters between those 2 days. And on the peripheral IVs, again, we always start with the patients that just came to the unit first, and then we'll start to round on the other patients afterwards. But we do kind of rely a lot on the nurses to be able to see and let us know if there's any problems that arise. Would it be great? Absolutely. And I get to that point, but also a pretty big challenge. But the fact that we are being proactive, it does mean that we keep our requested list down, which means that there's not as lengthy delays when it comes to a peripheral IV catheter that failed and they're waiting for us. So.
Okay, and I guess a somewhat related question, are there any inpatient departments that your team does not insert PIVs for?
So our ICU, so critical care areas, our nurses are taught how to put in IVs there. I will say that I still believe that they probably use us mostly. I'm kind of finding that in this world today. It just seems that once you really establish a team, they seem to want to utilize it. And the other example I use is our outpatient volume 1 year over another grew 75%. And what I think it has to do with is that people are starting to see us out there more frequently, so they're utilizing us more, but they also see us come in with the ultrasound and pop one in on the first try, and that just so it's a patient satisfier as well. So I'm really excited about that. The other area, obviously, labor and delivery, they do their own as well, but we do end up a lot in there because they really need the anesthesia really does request those large bores for those types of patients that they're worried about. So but those are every other area, we do them all. We actually just took all the catheters out of the Pyxis machine, so nobody can get any. Although when it does come to like RRTs, cardiac alerts, my team does respond, but they're also our nurses that come from the critical care area. So a lot of times, they'll help out and establish initial access, and then we'll go in there and get something better if need be. So.
Awesome, thank you. We actually have a few questions related to CPT or billing procedure codes. So some of our audience here is very interested to know if you could provide the CPT codes that are for billable services. And I don't know if you have these codes at the ready on this call here, but can you respond to that and how we can maybe share that with others?
So I have a bunch of questions. I am on vacation, folks, just so you know. I'm down in sunny Florida, and I found my prize shell with my hands and my feet, my lucky shell. But what I was planning on doing is tomorrow I was going to respond to any questions that I was unable to answer in Series 1 and Series 2. I could absolutely provide the billable CPT codes at that time as well, if everybody's good with that. And I'll get that
Absolutely.
over to you, Krista, and you can distribute it to everybody else as well. So I'll actually lay
Wonderful.
out exactly my whole productivity index and sort of how it works, and that'll include a lot of those. So
Great. Thank you so much. We
yeah,
appreciate it. I guess we are drawing short on our time, and I do want to be cognizant of that. If anybody has any additional questions, please feel free to type them in, and we'll make sure that we do get at least a written response for you
absolutely.
from Lee. But as we conclude today, I guess one last question was just, does your team provide phlebotomy services also?
Um, by default, yeah. So I mean, obviously, if we do a first stick insertion, wherever it may be in an outpatient ED setting, and they want blood, we'll draw it from there. But recently, we've seemed to be getting a lot of calls from the floor saying phlebotomy, was unable to get a patient. So would you be able and willing to assist? So yes, we have seen a very large increase in our blood drawing volumes, which is good in some ways because it is, again, a billable CPT code, so it adds some revenue. What I do want to work on and would like to work on with my phlebotomy is trying to develop a threshold of where they call us, maybe even as much as I hope my team's not listening right now, a little bit earlier than later, only because I do know that usually it's probably been a couple phlebotomists that have actually seen that patient before we get called. So, we all need to be working very hard to minimize needle sticks. It's wasteful, and it's just not healthy for patients at all. So
Wonderful. Well, we are at our time limit, and I am very appreciative of you taking time out of your vacation to speak to all of our attendees here today. We very much appreciate your time, Lee, and thank you to everyone here joining us
thank
on
you,
this
everybody.
session. Thank you all so much. We hope to see
Thank
you next
you.
week. Bye-bye.
Bye.